quite logical, quite easy, and we will see in our presentation that it is very easy to understand strabismus. In fact, strabismus was even in India, it was one of the oldest subspecialty before even retina became very common. So if you see strabismus, you would have heard of infraoblique recession, apt and call, Parkes recession. These are all very old procedures. The original article by Leonard Apt, and his friend, both. This was published way back in 1972, 1976, and a follow-up article in 1978. So this is like almost in fifth or sixth decade. So the Worthford dot test that we listen or read about is way back in 50s when India got independence in 1947. So we are talking about real 80 to 90 years back. Strabismus was a subspecialty since then. You must have heard of Burian, Herman Burian. He's the black and white guy with a tie. So he was the guy who actually wrote the first edition of Van Noorden. What are the goals of, we would see what is strabismus and what are the goals of examination. So why do we do strabismus evaluation? The reason why we do strabismus evaluation is first and foremost is to establish the presence and type of strabismus, whether there is any presence of amblyopia or not. That is very, very important because that gives you a unique opportunity to treat amblyopia, not only to treat amblyopia, but also to make patient aware that this strabismus is causing unilateral loss of vision. This strabismus is creating a binocular problem and a monoocular visual loss. So that is very, very important to establish whether there is any presence of amblyopia or not. The goal of examination is also to know the amount of deviation because we have to operate the patient and make it straight, and that is purely in terms of mechanics or in terms of vector. We have to find out what is the amount of deviation with the help of prisms. And finally, the whole reason why we are treating strabismus is to assess whether patient has a good binocular function or not. So that is regarding the reasons for strabismus evaluation. Now coming first to the fact that most important thing is before we embark upon hello. Yeah, so the first and foremost thing is to evaluate the visual acuity, and this visual acuity has to be evaluated separately for each eye and together both for distance and near. Now it is very easy in adults to assess visual acuity and children who are older than 3 to 4 years, but when it comes to very young children, it becomes very difficult. So these are some of the list of what visual acuity can be used. I know visual acuity is not really the topic, but it is very important that before we talk about strabismus, we have to talk about visual acuity in children, which is very, very important. So you can assess visual acuity by simple observation. You can have an optokinetic nystagmus drum. You can use visual evoked potential. These are all little rare things, and the common thing is post-choice preferential looking test, graded optotypes, and monoocular fixation. So these are some of the common things, but before we even talk about common things, we should be knowing what is normal, what are the visual milestones. So at 30 weeks of gestation, you can see that, if you see intrauterine, you can have pupillary reaction even before the baby is born. At 2 weeks, you can have doll's eye movement. At 4 to 8 weeks, so remember this is very, very important that at 4 to 8 weeks only, you will actually understand or you can see that baby can see vertically moving targets. It is very, very important. A lot of times, residents, students call up for their own kids when they become proud fathers or mothers that my Jitu bhai, my child is not seeing vertically. Only horizontal eye movements are present at birth. Vertically moving targets, this develops at 4 weeks. So this is very important visual milestone to understand that only after 4 weeks baby will start looking vertically and up and down. So this has to be understood. It could be before that, but after 4 weeks of birth, if vertically moving target movement is absent, only then we can say that this is abnormal. Now this is at 3 months, he reaches out to interesting objects. At 4 months, we all know that foveal differentiation is complete, and visual acuity by 6 months of age, at least as per VP, it becomes 6.6. By 9 months, see there's a difference between acuity being 6.6 in terms of VP and child being able to pick up, because vision will develop faster. But other functions are cognition. He has to have hand-eye coordination to pick up small objects. He has to understand that this is important, so he will go and he will remember and he will tell you. So that is where we talk about these 3 types of visual acuity. For recognition visual acuity, the child has to be at least 4 to 5 years of age to understand that he has to talk about E, C, hand. For 3 to 4 years, he can talk about Allen's or Schrödinger gardens or Lea symbols. But before that, we have to rely on optokinetic nystagmus, terror acuity cards, Kirier acuity cards, and Cardiff acuity cards. And before that, we can only go for detection, which is like 2 points. So you have to use candy beads. So these are all very small things. I know this is not pure strabismus, but this is very, very important. When a child comes to you and you are evaluating the child for strabismus, you should be knowing the normal milestones. Otherwise, it would be very difficult for you to assess whether this is normal or not. Say if a 3-month-old comes to you with strabismus and you start doing your examination on him, there is no need, because at 3 months of age, the child may overcome strabismus in a month or so. So the child can have exotropy at the age of 2 months, and his fixation may improve, his accommodation may improve, his convergence may improve, and he may become straight by the end of 6 months. So that is very important to know what is normative. Second most important thing before talking about strabismus is cycloplegic retinoscopy. Lot of problems are there in our examination, mainly because we do not control accommodation. Atropine is still the gold standard. There is no change in that. Home atropine eye drops can be used for older children. Yes, it is used even in private practice. We use home atropine eye drops if we want to have accurate refraction with adequate cycloplegia. You can reduce the concentration for younger children less than 3 months of age, which means that if you are using home atropine 2%, you can use 1% if the child is young. There are a lot of questions whether cyclopentolate can be used or not. Cyclopentolate is a wonderful drug for cycloplegia, but in our own experience, we have found that they have some neurological problems and we have stopped using it and we have switched over to homatropine. Nothing wrong with cyclopentolate. You can use cyclopentolate. So with this background, we come to the first and most important part of strabismus, that is motor evaluation. The second part is sensory evaluation. So motor evaluation, what will it tell you? It will tell you about measuring strabismus, knowing the type of strabismus, cover test, and assessing ocular motility. Now cover test, what does cover test tell you? Now this is very, very important because this comes as a theoretical written exam. In written exam also, you will get a short note or a full question of evaluation of strabismus. And cover test, if you write cover test properly, most of the examiners would understand that you have a good idea as to what is, that you have a good idea how to evaluate strabismus. So what does cover test tell you? The cover test tells you whether it is a ESO or EXO. So it tells you basically about the type of deviation. It tells you about whether it is tropia or phoria, whether it is unilateral or alternate. Then it tells you about the amount of deviation. It tells you about the fixation pattern. It tells you about the presence of nystagmus. It tells you about incommittant deviation. It tells you about presence or absence of amblyopia, dissociated deviation. So basically, overall cover test encompasses cover test, cover uncover test, alternate cover test, prism cover test, simultaneous prism cover test, a prism adaptation test, and corneal reflection test. So basically cover test encompasses the whole of examination. In short, if we say that cover test tells you everything, or at least most of the things in strabismus, there is nothing wrong in that, because cover test will tell you all these things. What do you need for cover test? you need a fixation target. Remember what I said, if you don't control accommodation and convergence, it is very difficult for you to know what is the type of strabismus and how much is the strabismus. So if you don't use an accommodative target, there is no way you would be able to judge, you will be able to measure absolutely accurate amount of strabismus. So you always need a distant accommodative target, a near accommodative target, an occluder, torchlight only for Hirschberg corneal reflex test. It has got no role in measuring the amount of deviation, and prisms, whether loose prisms or prism bar, there is nothing wrong in that. Now, before we start examination, there is a very gross kind of test which is known as corneal reflection test. Now, with the help of torchlight, we try to estimate whether it is ESO or exo. Now, depending on whether the light is nasal to the center of the pupil, then it is exotropia, or if it is temporal to the center of the pupil, it is esotropia. Depending on where the light is, you can say that patient is having strabismus. It is almost like lay terms, it is very inaccurate, and we do not advise to measure strabismus based on corneal reflection test, but you can make a gross idea. This could be taken as part of inspection when the patient walks into your clinic or walks into your room. Grossly, corneal diameter is 12 millimeters, half of this would be 6 millimeters. Light reflected limbus amounts to 45 degrees. How do we come to this point that it was 45 degrees? Way back in 1885, Hirschberg, on whose name corneal reflection test is there, Hirschberg corneal reflection test is the name of the test. So Hirschberg published in 1885 that when the light reflects at the limbus, it would amount to 45 degrees. And therefore, each millimeter of eccentricity amounts to an approximate angle of 7 degrees. Now, we done our own calculations. We presented this in 2011 and we found that actual angle is not really 7 degrees. Now 7 degrees is an underestimation. 7 degrees would mean it is around 12.5 to 13 prisms, whereas an actual per millimeter of eccentricity would lead to around 18 to 19 prisms, and it all depends on the corneal reading, because the curvature of the cornea determines how much would be the angle of eccentricity per millimeter. But this is a gross way of evaluating what is the amount of deviation. Now we come to cover test. Now cover test, the first step is to cover the seemingly fixating eye. Now which is the fixating eye in this particular animation? Can anybody answer which is the fixating eye? This is the right eye and this is the left eye. So which is the fixing eye?
Right eye.
Okay. So what we do in cover test is we cover the seemingly fixating eye. We have covered the seemingly fixating eye. What has happened? The right eye under cover left the fixation and the non-fixating eye or the left eye took up the fixation, right? And when we uncovered it, what happened was the left eye again left the fixation and right eye took up the fixation. What does this tell you? This tells us, the first step tells us that it is a exotropia because eye came from out to in. The second step tells us that it is a left eye exotropia. It is a unilateral squint because right eye again took up the fixation. If right eye would not have taken up the fixation and left eye would have maintained the fixation, what would it then be? Then it would be an alternate tropia. This is cover-uncover test of an intermittent exotropia or a exophoria, where you don't see any deviation. So what you do? You cover any of the eye, but you don't do alternate cover test at this point of time. See, alternate cover test is different from alternate tropia. These are two separate things. So we should never confuse by doing alternate cover test. If we come to a conclusion of alternate exotropia, that is wrong. Alternate exotropia means if you do a cover test and you do a cover-uncover test, if the eye leaves the fixation and other eye maintains the fixation, it is alternate tropia. Whereas alternate cover test is done in cases of orthophoria, exophoria, esophoria, when there is no seemingly fixating eye. So this is the conclusion which we do with cover test. The seemingly fixating eye is covered, which means that eye which looks to be fixating is covered. if you cover the non-fixing eye, you don't get any result. You don't get any information. You're wasting your time by covering the non-fixing eye. I will show you the video, but you have to cover the fixing eye. The response of non-fixating eye is observed. If the eye comes from out to in, it is exo, in to out, iso, up, down to up, hypo, and up to down, hyper. Simple as that. So this is, now which eye is the seemingly fixating eye? Left eye is the seemingly fixating eye. Now we cover the left eye. What happens? Right eye comes up in the center, right? So it is right eye exotropia. You cover the left eye, that's it. That is cover test. You cover the left eye, right eye takes up the fixation. That is cover test, right eye exotropia. Now once you have covered the eye, you are going to leave it. Once you leave it, there are only two things that can happen. Either this particular eye may hold the fixation, then it is alternate tropia, or it may lose the fixation, then it is unilateral tropia. The eye may hold the fixation but may lose it after a blink, and then it is alternate deviation with one eye dominant, or a master eye, or a mild amblyopia, or an intermittent deviation. So we come back to where we were. Yeah, so this is, now you have covered the left eye. Now you leave it. What happened? Right eye went back. So what is this? What does this tell us? This tells us that this is a right eye exotropia. This is right eye unilateral tropia. Do we agree upon this? So on covering the left eye, right eye takes up the fixation. Now we cover the right eye. What information do we get? We don't get any information. What do you get by covering the right eye? Absolutely nothing. So wasting your time by covering the non-fixing eye. So what happened? Right eye appears outward, left eye is the fixing eye. Is alternate cover test when none of the eye is fixing. Any one of the eye is covered and then uncovered, and to see whether whether it is esophoria or exophoria, we uncover it, and then to break the fusion we do alternate cover test to manifest the latent deviation. This is what we saw already, alternate cover test. Now we covered this eye went out, then we did alternate cover test, we covered the other eye, and then we covered this eye. So this is alternate cover test in cases of intermittent exotropia or when there is no deviation. And then there is prism cover test. Why do we do cover test? We do prism cover test to know the amount of deviation. How do we know the amount of deviation? We keep apex towards the deviation. Why do we keep apex towards the deviation? Everybody knows that? Can anybody tell why do we keep apex towards the deviation? See, if you have exotropia, if your eye is moving outward, what will happen is your fovea will move inward and a non-foveal temporal side point will come into the center, right? When you put prism apex towards the deviation, which means if there is exo, you are keeping apex outward and base inward. What happens with this is when the light passes through the prism, it always bends towards the base and image moves toward the apex. So what you are trying to do is you are trying to move the image towards the eye which is outward in such a way that when you cover the non-fixing, when you cover the fixing eye, there is a movement of redressal. The fixation movement is known as movement of redressal. When the movement of redressal occurs, if you put a prism, if you put an appropriate prism, the total amount of deviation, then this eye will stop moving. It will have that particular image at that point itself. So it doesn't need to move. The image will move towards the apex and light will move towards, and we know in exotropia the fovea is already moved nasally and extrafoveal point is in the center, and when you put prism in such a way that it bends the light towards base, if you put base inward, the image will move outward and light will bend towards the nasal side. Do you can you understand that? This is very important because they can ask you this in they will. Am I audible?
Yes, sir.
Good. So no, because because I was not getting a response, I thought maybe I'm not audible. So uh, do you get the point why we keep prism apex towards the deviation? Okay, good. So when we write this, we write for ESO, we write base out, which means that apex is the eye is towards the nose and the apex is towards the nose. So we write base out. So whenever we write in terms of notations, it would be base out for ESO, base in for exo, for hyper, base down, and for hypo, base up. The reason for this is because the first people who started this started doing like this. And so this has become a norm. So everybody expects us to follow the norm. This is like units. This is like meter per second. This is like units. We have to just remember that. And then there is Krimsky's test. What you do in Krimsky, so Krimsky was a brilliant scientist. What he thought was, if you put an appropriate prism, the light reflex will come in the center. So what he did was, he used to put prism in front of the deviating eye. And then there was modified Krimsky's test, which we all of us do. That is known as Krimsky 2. We put prism in front of the fixing eye, the better eye, because it is easy to judge whether the better eye is moving its fixation or not. So you put prism in front of the better eye and then you watch the non-fixing eye to come in the center. I'll show you the video of all this, but it is a good idea to hang on to this. And then we come back to Scobie-Marlow's occlusion test, which is basically you occlude the eye in intermittent exotropia for 45 minutes and then reassess the patient to break any, to break him of any fusion that he may have. Now this is just to show you a small animation of alternate cover test. This is patient is having exotropia. We are putting an appropriate prism in such a way that you do an alternate cover test. Here you always do an alternate cover test because you want to find out the total amount of deviation. If you do a simultaneous prism cover test, you will only get tropic deviation. When you do an alternate cover test, you get total full amount of deviation, and whenever you want to operate, you want to operate for the total amount of deviation. You want to operate for the hidden latent deviation also. Now this is just to show you a video of prism bar cover test. Basically it is very similar to what I said.